choose a doctor that you're comfortable with. We have to get past being afraid to have these conversations, and I think one of the biggest barriers is choosing someone that you really feel like you can take the barriers down, someone that you can relate to, someone that has shared lived experiences because of a common background, and then potentially take someone that can advocate for you, write your questions down before you go. Pray about your decision, ask the Lord to lead and guide you in all your steps, show you the direction that you should go in, have a plan, and have a backup plan. Make sure that you can advocate for yourself, ask what are the risks, the benefits, what should I be looking for, do your research. You're not subject to what someone chooses to tell you, because they can also choose to not tell you things as well. So you want to make sure that you're prepared. You don't want to go into those situations blindly, and don't leave God behind. Take him with you. He cares about every aspect of you, every aspect of your health. It's not just for that over there, but it's also, he cares about your mental health. He cares about your physical health. He cares about all of those things, and don't neglect to remember those things.
Thank you so much. To piggyback off that question, I want to ask you, how is it whenever you are choosing a doctor, how is it that you can get past, what are the steps that you can take to finding the correct doctor for you? I know that sometimes we're like, oh yes, we want to find an amazing doctor and whatnot, and I've been using the same doctor just because of convenience. And I know a lot of people, they just kind of went to the doctor that their mom or dad went to, and they don't really know how to branch out and choose their own doctor. So what would be some practical steps to researching proper doctors to go to and branching out?
Start by finding out who's in your network. That's important. Beyond that, do your research, look up their bios, ask your friends, have conversations, ask the women that you trust, because those are the opinions you value the most. Look at reviews, but take them with a grain of salt. If you see a pattern in reviews, then there's probably something there. If it's important to you to have someone who looks like you, then look for that, or at least someone who you feel like you can relate to. I think those are some good places to start. There are good review sites online. There are some that are made specifically for us. There are some that are specific to maternal health that I think can be very important, because you also want to look beyond just the physician themselves. You also want to look at the support system, where are they located, what additional resources do they have if it comes to maternal health? Are there lactation support? Is there social work? What is their stance on doulas and midwives, since that's my area? You also want to know how that doctor is supported and what other resources you can tap into. What hospital do they deliver in? All of those things are very important. But having those conversations is where it starts.
Thank you so much. So shifting gears, we are going to hop around a little bit, just to make sure we're catching a broad scope of questions. The next question that I have is about PCOS, and this is for you, Dr. Janelle. Can you tell us a little bit more about PCOS and what it is, how it actually affects us? I feel like people, this era of TikTok and Instagram has given us more exposure to what PCOS is, but I don't know if all of us fully grasp what it actually is. If you could please elaborate so that some of the women can gain some more knowledge on it.
Sure. I am going to give my mainly experience. We do have the medical doctors here on the platform. So after I'm done, if you guys want to chime in and offer your expertise. I know for me, one of the main signs was a missing period. If you can go longer than 35, 40 days, something may be going on there that's preventing ovulation from happening. And so that's a primary sign. Another one is if you check your sex hormones, if your testosterone levels are high, or even your male hormones, other male hormones like I think is it DHT or, again, I'm not a medical doctor, but Missing periods, so going longer than 40 days without a period, high testosterone levels, and sometimes physical signs, like if you're having male pattern hair growth, hair on the chest, hair on the chin, those can be signs of PCOS. And through, I think, a pelvic ultrasound, you may have multiple cysts on your ovaries. The smaller ones, not necessarily the big ones that lead to a ton of pain. So those are some of the signs. It's the number one cause of infertility. So it's definitely something to learn about and potentially try and get a diagnosis as early as you can. I don't know if you guys want to add anything to that.
So you guys talk about how we don't understand what PCOS, but honestly, in the medical community, there's a lot of debate about what PCOS is and has multiple names. But PCOS in general is a diagnosis of exclusion. That means that we have to do a bunch of investigations to make sure that the symptoms that you are experiencing aren't being caused by other things, because if they are, we have to take care of those things, and then rather than giving you this broad diagnosis that isn't well understood, and then we're trying to basically put a tape over each issue as opposed to dealing with the issue. However, the most acceptable diagnosis is after we have ruled out everything else, you have two of the following three symptoms. One of the symptoms is that you either have clinical signs or laboratory signs of excess testosterone. Every woman has testosterone. That's what makes us vital. That's what makes us have a sex drive. That's what makes you want to get up and go. That's why bodybuilders use testosterone, because it makes you vital, vitality. But there is a level that women have that is acceptable. And there's a level that PCOS girls that have that is 10 times what normal women have, but a lot less than what men have. So let me just use like broad numbers. So let's say every woman around here has a PCOS or has a testosterone number of 10. Well, if you have a man, if you're a man, you have testosterone levels of thousands. But a PCOS woman has a testosterone level of 100. It's 10 times more than what a woman that doesn't have PCOS has, but it's nowhere near the thousands. So just so you understand, okay? But how that can manifest is that you have hair in the midline. So in the midline of your body, because hair in your arms and legs, that doesn't count. We all shave our legs, we all go get lasers, that's fine. But if you have a beard or you have a little bit of a mustache or you're always doing electrophoresis or always getting threading, that's not normal, okay? And that also usually also manifests in having acne or having male pattern baldness. Like you should not be balding, right? You shouldn't have male pattern balding as a woman, but you can experience that with PCOS. Then the next symptom is you don't have regular periods, okay? That means that you're not ovulating. You need to ovulate. You need to release an egg every single month, and then you should have a period to follow. But if you don't have that, that's considered that's part of the second symptom. And the third symptom is multiple eggs on your ovaries, which means that you kind of formed a cyst that was supposed to ovulate and you did not ovulate. And so those are the little cysts, okay? So there are people that have PCOS that don't have cysts around your ovaries. So that's why it's a misnomer in a sense.
Thank you so much. Dr. Woodus, do you have something to say?
I wanted to add to that we had mentioned in the last panel how we got excited when we didn't have our cycle because we had a history of PCOS, but you actually need to come and talk to us. That's actually not normal and can be very, very dangerous because what happens over time, if you allow that tissue in the uterus to grow thick, it could potentially grow out of control, become precancerous, and increase your risk for uterine cancer. So we want you to have at least 4 periods a month. We don't want you to go more than 3 months without a cycle. And if that's your story and you're not on any medicines to control your cycle, you need to come and have a conversation with us. So when you're not worried about childbearing, we need to make sure that you have a regular cycle because we're protecting your health. And we can do that in a variety of different ways. Sometimes it's just a conversation about lifestyle changes. I've had patients who have improved their diet and exercise, who focus on certain supplements and nutrients, who improve their menstrual their menstrual health. I've had other patients that have had to put on medications, whether they be hormonal or non-hormonal, but it's important that you understand that it is not normal and can be dangerous for you to go long periods of time without a cycle. And we're seeing cancers at much, much younger ages. So this is a big deal. And then when you get beyond that and you get ready for childbearing, we need to have yet another conversation, because if you're not ovulating on a regular basis, it's not impossible to get pregnant. Don't let anybody tell you that. But it might take you much longer, and you might need some assistance in understanding and learning your body, or with even considering medications to help you ovulate. So it's a deep conversation.
Thank you so, so much. I hope somebody's getting blessed from these answers here. So kind of going off of that, Dr. Janelle, I know we were talking about sexual matters and childhood and whatnot in the last session. So a question that we have here is, at what age do you talk to children about sexual health, and what terminology do we use when doing so?
This is a great question. I would say that as early as 7. Obviously, we're not teaching them to have we're not teaching them sex ed, but anatomy, I mean, you can definitely teach them. They're taking showers or baths. So I do think it's important to teach them how to wash the vulva. And during that time, you can teach them the proper names. This is your vulva. This is your vagina. You don't wash inside of here. If anyone touches your vulva, tell your mommy, tell your daddy, tell someone. No one should ever touch that name, not the flower. And so I think those are some places that we can start. I don't know if there's moms on the platform, but I think that's a great age. Waiting too long may be too late if something already happened.
So I'm not a mom, but I do want to piggyback on this, because there's a number of things that we need to talk about. The first thing is that Black girls have their periods earlier. That's not something I said. That's something that the data shows, okay? And so 7 is a good time, because Black girls are having their periods as early as 8. And so it's very important that that is talked about before they are now in a position where when they're having their periods, they have the ability to get pregnant. And I have delivered an 8-year-old before. So that is very important, okay? And the second thing that I wanted to, and there are some of them that are having STDs earlier. So there's a lot of things that we are seeing that you might never cross your mind. You know, we're saints, you know, it might never cross your mind, but it's happening. And so, and then the other thing is that actually the American College of Obstetrics and Gynecology says that we should be actually having our first gynecology appointment at 13. So a lot of people are relying on the pediatrician to teach them, but the pediatrician has a lot to do. Got to make sure your baby's growing. Got to make sure your baby's healthy in so many other ways. And we can sit there. A lot of us that are gynecologists, and usually I'm a pure gynecologist, so I don't really do OB anymore. But when we talk from gynecology, we can sit with you and we can talk to your daughter, especially the things that are difficult for you to explain. Maybe you didn't have the education. And so we can help you, and we can give you resources to be able to use the right words. You were even calling it a flower. There are people that call it the ugly. I mean, like, you know, you say flower. I mean, we hear the ugly, the bumping uglies. What do you think uglies are? You know, so we use even other terms that are derogatory, not even just something that takes the place of. You know?
Wow, no, that's actually amazing. Thank you so, so much. I mean, we're getting a lot of these sex ed questions, so you guys just buckle up and be prepared. I'm just telling you, sorry to the men who are in the room, but at least you will learn for your wife and your children. Amen. So another question that we have here, and feel free, anyone, I know Dr. Janelle, this is more of your expertise, but please, anyone feel free to hop in as well. This one says, the pain and performance issues that lead to prevention of any kind of penetration, do they have any impact on the actual delivery of a child? I'm reading that question, but I don't know if you need me to rephrase it, or do you understand the question that's being asked?
I understand it, but I think I'm going to let doctors who do the delivery, because I'm sure y'all see women that have vaginismus or sexual pain in those cases.
Thank you.
So vaginismus is really important, and honestly, I think that the amount of religious influence on vaginismus is like insane. And I'm not just talking about Christian. I'm talking about the Muslims go through it, boy. They go through it just like we do. So, and what we experience is even from like discussing what type of feminine hygiene product to use. So a lot of, and if you're Nigerian, I'm so sorry, because I know us very well. We're told that it's dirty to put anything inside. So there are women that have actually never used a tampon before, right? Because they're told that this is dirty. It's dirty for you to do this. So you're going from never having a tampon, never seeing a gynecologist, then you try to get pregnant, or you get married, and now you're supposed to like, you know, be doing all of these things. And so when they come to us, we experience that we can't even put a speculum in. We have difficult, I mean, the first thing that any gynecologist is going to ask you is, were you sexually assaulted? And when you're not, maybe you haven't experienced this, you're one of the 2 out of 3 women that did not experience it, you might be dismissed. Or we might be like, well, this is just going to have to be how it is, right? You're like, oh, girl, that's only that? You're only 1 centimeter. Like, you're only 1 centimeter dilated. You got to get to 10. Like, everyone is going to be in here. And, like, the conversations are really kind of late if you're having those in the delivery room. It's really, really late. And at that point, because at that point, there's a lot of things that are happening. There's a lot of things. It's a really high stress area, which is why I'm retiring from it. It's really, really high stress, right? But there's a lot of things that are happening. So with us as Christian women, and you're in a position where you've gone through the process of now you know what you have. You have pain. You have painful intercourse. I almost said down there because I do a lot of work on social media, and I get shadow banned if I even use the word vagina. So I say hoo-ha, poom-poom. I've used all the other words. But what we explain, or what we have to do is, I need you to talk to your doctor about this. I need you to talk to your midwife about it. And if you don't feel comfortable with either, they shouldn't be a doctor or midwife. But you should at least talk to your doula about this, because these are discussions that should not be waited to be had on labor and delivery. These are things that, because I have patients that used to come in with a laminated birth plan, and like laminated, so that any kind of bodily fluid is not going to make me not see what they were out. Okay, but then we haven't discussed what's really important.
If you have these discussions early enough, you can come up with a plan, you know. You can come up with a plan of attack so that you both can feel comfortable. And when you really find a provider that you feel comfortable with, you've been with this person for 9 completed months. So you've had plenty of time, essentially, in a lot of cases, to work through, you know, feeling safe with that provider. You know, understanding exactly what the steps are to this exam. Why are we doing this exam? What do I gain from this exam? Why is this important? And I find that when you slow down, take a breath, and have those conversations, anyone who had a lot of anxiety, a lot of tension, a lot of opposition to having those exams, just that understanding and that knowledge breaks the barrier down so that we can make some headway. Find a provider that you can have those conversations with. Know that that person is not going to violate you or do anything to you that you do not want done. I think that when you understand why it's important, that helps you get past the pain and the discomfort. And what can we do about it? Can I pre-medicate ahead of time? You know, there are medications that we can use to help you get through that exam. You can have a safe person in there with you to advocate on your behalf. If you need to, we can limit the exam. Sometimes they're not necessary. We can find the information in other ways. Maybe we can do an ultrasound and get the same information. So there can be workarounds, but you have to be open, and you have to not wait until it's too late. Like in the delivery room, it definitely is too late when you're in the delivery room. The epidural helps a lot in the end, but definitely those are conversations from day one that we need to be working through, because it's a process.
Thank you. Dr. Janelle, you want to say something?
Briefly, I just want to say that there are women, if you struggle with vaginismus or sexual pain, there are women that don't even overcome the vaginismus completely and still go on to deliver vaginally. So even if you've never had, this is not the Virgin Mary thing, but you can literally could have never had penetration, ever, and you're able to have a vaginal delivery. I wouldn't encourage it. If you're able to see a pelvic floor physical therapist, you can recover those muscles so that you have a better connection with how to relax your pelvic floor. Because if you're having difficulty relaxing it for intimacy, for even emptying your bladder, imagine trying to relax it enough for a baby to come through there. So we don't want to be straining and straining so much, because that's going to make it more difficult to deliver with less complications. So if you can, ask one of your medical doctors for a referral to a pelvic floor physical therapist to help you prepare your pelvis and your pelvic floor for the birthing process.
Thank you, thank you, thank you. Please, 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 ladies, be listening. I'm learning a wealth of knowledge here. So the next question that we have, I know we spoke about this, Dr. Janelle and Dr. Yenny spoke about this in the last session, about being comfortable with your body, right? But this question is kind of about how comfortable is too comfortable. With us being Christians and Christian women and trying to uphold the values that, you know, God has placed before us, how do you explore and become familiar with your vagina inside and out without crossing into a line of self-pleasure and sin?
So I actually tell my patients to do a vulvar exam every month like you do a breast exam every month. First of all, you should be doing a breast exam every month. Let's start there. Breast cancer is very common. 1 in 8 women will have breast cancer. And Black women tend to have breast cancer that is more deadly because we wait too long. We see it, it looks like an orange, like it has puberty orange, like it looks like an orange. And you can feel it's hard, and you still don't do anything about it because we're preying on it. We're preying on it. So vulvar exams are as important. I tell my patients, like, you know, when I pee, urinate, I look back in the urine. Is it clear? Is it look like RC Cola? Did I drink water today? That's the same way you should look at your vulvar. Because melanoma, which can be deadly skin cancer, is found underneath the feet and around vulvas in Black people. And you don't look. You don't know what the difference is. You have no clue, right? I feel like I'm scaring everybody. They're like, it's like, get off. But it is really important. You need to know what it looks like so you'll know what it doesn't look like. I've had patients who have been, and this is actually, I'm going to talk a lot about my patients because they give us a wealth of knowledge, so bear with me, because some of it is a little bit scary, but there are reasons why I'm telling you this. I've had patients who've thought forever that they have folliculitis, which is an inflammation around the follicle of an ingrown hair, perhaps, right? A lot of them are not aware that they have genital herpes, right? And then we figure this out while they're pregnant, right? And so you need to know what's normal. You need to know what's not, because if you know what's normal, when something new pops up, I'm telling you, I have people of, I'm sorry, Black women of other races, they come in and they're like, this wasn't here yesterday. It wasn't here yesterday. And we catch it early because there's a great thing is prevention. But the next best thing is secondary prevention, which is you have something, let's fix it early so it doesn't get worse. That's the next best thing. You might not be able to prevent everything best in your life, but hiding your head in the sand or getting into your prayer closet is wonderful. But faith without action is what?
And you don't just accidentally start masturbating.
Yeah.
So I know the question was, how do you differ between? So, I mean, yes, that temptation will be there, guys. Temptation. Pray, stay in your prayer closet. But know that you won't just accidentally start rubbing it out. All right? So I think start understanding that God wants you to be knowledgeable, that we have an opportunity to prevent things. And so looking down there, making sure that things move, the clitoral hood should be able to move. It shouldn't be stuck, right? So all these things are things that we have to check on. And if you feel like it's about to start slipping to a different territory, you better run.
No, that's definitely true. Thank you for that. I hope whoever had that question, I hope that helped to answer it. So, here still on the line of sex, we're going to get a lot of those questions here today, just to let you guys know that. But, here, I want to ask this one. It says, how would you address someone who associates sex with how they keep a man? We see this a lot in this society now with the, God forgive me, Cardi B's and the Megan Thee Stallions, and they have basically promoted sex is what draws the attention of men and keep them there. And we know that that's not necessarily true. So, like, how would you speak to this type of person? How would you address them in this realm? Dr. Woodus, if you want to answer.
Okay. So I have this conversation quite a bit with my mama. My mom is a geriatrician. She's 71 years old. Geriatrician is a physician that takes care of older people. And so we have this conversation a lot because she says a lot about your generation versus my generation kind of discussion, right? So not counting the fact that her generation had 17 kids. So clearly they did stuff to get there. But she kind of talks about how, like, our generation is more sexual in nature and things like that, and everything goes type of culture. So let's kind of talk about it, because it doesn't cross the line because you're born again. Right? We know that. Like, it doesn't cross the line because you're born again. So when we're talking about intercourse, sex is really important in intimate relationships. Sex is really important in marriage. Sex is really important in marriage. It's how you communicate in a way with your partner or your husband or wife that nobody else can communicate with that person. So it's really important. But if that's the only thing that's important, if your marriage is not built on the rock, on the foundation, we have a problem there, right? Now, the problem I think this person is talking about is, I met somebody that I like, and the ring is not forthcoming. How am I going to get from there, this person that I like, to the ring? That's the problem. That's the gap. And the enemy has told us that that's the only way, because if you haven't tested the car, I don't know when women became cars, but if you have never test drove the car, how would you know how it whips? Like, there are so many questions that comes in, and we cannot, I think these are the issues I have with us in the church. We're not talking about that. We're saying, cross your legs, wear your chastity belt, and pray to God with that fire. These are real issues, and we talk about it. My patients and I talk about it, because there's a lot of us that waited. I'm 38. I got married at 38. So there's a lot of us that were going to be geriatric, quote-unquote, pregnancies even before we got married. So there's a lot of us that waited and waited and waited, and we might get into the situation where we're now dealing with, you waited, you now can't have intercourse, or when you have intercourse, you still think it's a sin because it's not a switch, and then you wonder, you know your husband, you're not his first partner. So who else has been, doing all the other things that you don't even know, or you think is disgusting, right? There's so many other things that we need to talk about. So I do agree that, and I am not a pelvic floor physical therapist, but every pelvic floor physical therapist that I've ever met knows that I think that everybody should see a pelvic floor physical therapist before they get married and after they have a baby. 100%. After you have a baby, you better be safe. And for those of you that have gone through miscarriages, I know I'm going on a little bit of a tangent because it just came to me. For those of you that have gone through a miscarriage, an abortion, or an ectopic pregnancy, you have had a loss. You have had a loss. I take care of a lot of women that are in the menopause. and they are still grieving a child. They're in their 70s, they're in their 80s. They're still grieving of what could have been, even if they made a decision to end the pregnancy. Because most of us don't say, I'm just going to end the pregnancy. You're not in the right place. You don't have the right partner. You are afraid of the shame. You're afraid of the shame that the church is going to give you. I recently spoke to a girl who was a minister, and in that branch of churches, you're not allowed to get married without a pregnancy test. If you're a Nigerian, you know that happens. They will do a pregnancy test before you walk down the aisle. And she was engaged to be married. She said, you know what? We have been doing something. Let me go and check before I go there and embarrass myself. So she went and checked, and she was pregnant. So she did a medical abortion so that she would not be not married by this pastor. If you're a doctor, you know that the pregnancy hormone is not a switch. It still declines. So when they did do her test, she was still pregnant. And they sat her down. Y'all know what to sit somebody down. We're Christian folk. They sat her down, and they sat him down. So she ended a pregnancy that she really would have wanted in order to when we talk about we have the power of God, but we deny the power therein. That's religion. Yeah. That's religion. Or I've had patients where they're on their seventh abortion, 41. And why? She's engaged to a pastor. And she has no desire. And they've been engaged for years and years. And this is her form of birth control, because birth control is sin. You see, this is the things that we as Christians, I was a resident when this happened. My colleagues were like, I have no idea. I said, I have all the ideas. All of them. I have all the ideas. So I think that as we as Christians, I think there's some things that we kind of, bite our noses to spite our face, in a sense, right? The things that are shameful, we still do because we're human, right? And we find ways to cover up sin because sin begets sin, and sin begets sin, and sin begets sin. So I think that the answer to that question is, if your foundation of your relationship is not built on Jesus Christ, on the rock that is, there's not a amount of sex that's going to keep it. There's just not. Period.
Wow. Thank you so much. You literally probably answered about 3 other questions that were in here. So thank you. Dr. Janelle, I saw your hand. Did you want to add to that?
Briefly. So
Okay.
We as pelvic floor therapists, we see a lot of women thinking growing up that a tight pelvic floor or a tight vagina is good. And I think that also comes from male pleasure and where they derive pleasure from. But we our company is doing well, so we just untighten vaginas for a living. And so just let it be known that tension is not necessarily good, and a tight vagina is not going to keep a man, as this doctor has said here. I always say a tight character of the man is the only thing that's going to keep him.
Yeah.
So look for character and not sex as the holding power.
Thank you so much.
And if he doesn't want to be kept, he's not going to be kept.
That's right.
He's just not going to be kept.
Say that. And please, reminder that the vagina, just like the heart, is a muscle.
Yes.
Don't think of loose or tight, it's some muscle. Okay. Thank you. I just wanted to quick hint for the office agenda in the room. Anyway, so another question now. We're kind of going into a different direction. Can we address postpartum preeclampsia? An alarming number of women are not aware of this. What steps can we take to either prevent or lessen the impact of this? It goes unnoticed. I didn't know about preeclampsia until maybe again, the era of TikTok is teaching me everything. So please, if you could elaborate from some of us in here.
Let's talk about what preeclampsia is. So preeclampsia is an elevation in your blood pressure in severe range. The numbers that you need to know is anything greater than 160/110 is stroke level blood pressures, and we need to be conscious of that information. It can be associated with symptoms like a headache that's different or unusual for you. This is the worst headache of your life. You've done all the things that you know to take care of the headache. You ate something, you drank something, you rested, you took Tylenol, you had caffeine, and none of those things are helping. It can be visual changes, not because I got up too fast or I moved too quickly. This is I'm just looking at my cell phone, I'm looking at TV, and I've got a deficit in my visual field. Extreme swelling, I wake up in the morning, I'm 10 extra pounds. We expect some fluid retention after delivery, but that's too much. So it's a constellation of symptoms, a disruption in your body that can throw things off balance and increase your risk for a stroke and can damage your liver function, your kidney function. We are predisposed to preeclampsia a lot of times because we have chronic hypertension as Black women. So it's important that we know our family history, that we are being watched well, that someone has had these conversations with us, that if we have any blood pressure concerns, we've had a preventative conversation with our physician about the importance of aspirin and how that can help to decrease our risk for preeclampsia, and if we do have blood pressure concerns, how it can help improve our outcomes. We need to make sure that we have a blood pressure monitor at home that works and we know how to use it, and we need to know what the danger parameters are as well, and in a way to effectively communicate with our medical team when we do have concerns and not be afraid to speak up. So you also need to have a partner that's aware of those things too, because in the postpartum period, we've got all kinds of things going on, and we may think that some things are normal that are very abnormal. We also are not getting the follow-up that we need in the postpartum period. That's something that's been neglected for quite a while and is a deficit in terms of a missed opportunity for us to stay on top of health issues. So early postpartum follow-up, if you had any concerns with blood pressure during the pregnancy, within that first week of going home, you should be seen again. And then just having those precautions in place is what you need to be aware of.
So, such a fabulous job in talking about preeclampsia. I from an intellectual standpoint, preeclampsia is really interesting because preeclampsia is actually the working theory of how it's formed or how it develops is that the placenta is given off hormones, right? So a lot of people think if you deliver, the placenta is out of your body, so we have nothing to worry about, right? But we know that preeclampsia is actually seen, 1/3 of preeclampsia is seen in the postpartum period, 1/3. So 1 out of 3 women who have preeclampsia have it in the postpartum period. And why is that? Because the hormones are also not a switch. They're going to still be active, sometimes up to 12 weeks after delivery. But we know that there's a window where everything kind of equilibrates, where fluid shifts really happen. So very, very important are days 3 to 7 postpartum. So those are days you want to be taking care of your blood pressure, checking your blood pressure. You usually want to check your blood pressure when you first wake up. Is not the right time. Everyone is angry to wake up, okay? So I usually tell patients about 2 hours after you wake up, you want to take your blood pressure, you want to be seated, you don't want to be talking, you want to take your blood pressure and see what it is and just write the numbers down. The numbers that Dr. Woodus put out there is something that you need to remember. 160 over 110, remember it for your best friend, for your sister, for your wife, for everybody. Those numbers are not normal. We've seen some devastating things happen. And imagine having a young baby there and you have someone that's seizing. My sister had eclampsia. So eclampsia now goes beyond because there's a range of blood pressure issues. There's everything from gestational hypertension, pregnancy-induced hypertension, preeclampsia that's mild, preeclampsia that's severe. Your lab work can go crazy. You can have eclampsia. Eclampsia is actually having the seizures. People have strokes, right? And we see this more often with Black women because, first of all, we are predisposed to blood pressure issues in general. Everybody got the blood pressure issues. All your grandma, everybody's on blood pressure medication. So one of the things that you can do is also limiting your salt intake, watching your weight. You shouldn't be gaining weight rapidly. You gain weight in pregnancy, but you shouldn't be gaining weight rapidly. You should stay active during your pregnancy. You can do all these things. By the way, my sister is like 5'11" and 140 pounds when she was pregnant. She's 110 pounds now. So you can be of normal weight or even underweight and still have these issues. So it's not a weight-related issue, but it can be, you have an increased risk factor if your weight is elevated and if it continues to grow out of proportion while you're pregnant.
Thank you so much for that. The next question, this one is directed towards you, Dr. Ruthie. It says, can you please talk about the cosmetic surgery and improving confidence with women who have had kids? For example, breast lifts, breast augmentations, tummy tucks, the mommy makeover, those type of things.
Finally, I don't have to ad-lib. Oh, I love this question. So I actually went into, so I'll tell you guys a little bit about my story while I explain this. I went into cosmetic surgery because my patients told me to. So I finished my OBGYN training. I did GYN surgery training. I opened up a practice where I was just doing fibroids all day, every day. Fibroids, fibroids, fibroids. One of my patients said, you did such a fabulous job. Oh, my incision, I can't even see it. Are you sure you don't want to do my breasts? I said, girl, I don't know nothing about that. And then she said, well, when you figure it out, I'm going to come to you to do my mommy makeover because I'm going to get pregnant. She had no kids. I'm going to get pregnant. And after I get pregnant, have these kids ruin my body, you're going to do my makeover. I said, this girl is nuts. I'm tired of school. And then another patient said something very serious, like the Holy Spirit kept, you know how you go, if not, you're going to Nineveh. You're going to keep going. I'm going to keep going. I'm going to keep going. So I finally, that's kind of how I got into it. So for me, it's a ministry. I don't do surgery. Surgery is a tool that I use to make women feel more comfortable in their bodies so that they show up as better wives. They show up as better daughters. They show up as better friends. Because when you feel good about yourself, you can be you. You can really show up and show out. So that's what I do. So mommy makeovers are just a tool to help restore you. I actually have a friend who trademarked, oh God, if she knows that I use this name, she's probably going to find me. She trademarked it as mommy restoration. I'm restoring your body. I don't do surgery. I can't make you look like Nicki Minaj. I ain't got it. I make you look like you.
Yeah.
I look at the lines that God gave you. I did surgery on I've actually done surgery on my mama. She likes everybody to know that. At 70 years old, she had grandmama makeover. But she said, no, she's not going out. She's going out fighting, okay? So I had a friend that I recently did surgery on, and her situation was, she had she was married. She's Muslim. She was married. And one day, she went outside to get her car, and her husband was gone. 2 kids, husband was gone. Didn't hear from him for 3 years. Okay? Just woke up one day and just didn't want to be there. Okay? And during that period of time, y'all know, when you go through a heartbreak, you're either going to gain a lot of weight or you're going to lose a lot of weight, right? Well, she was the former. She was like a shell of herself. So I recently did surgery on her. She had done some weight loss on her own, and I helped her do surgery on her. When I did surgery on her, I have never done surgery on somebody that the fat literally did not want to be there. Like, as I was saying, it was like literally pouring out. The fat was just pouring back out, right? Lifted her breast, it just sat. Like, that's where it just sat there. And so those kind of things to me remind me of, it's almost like restoring what God already made. I didn't do anything special. I did the simple surgery. A little lunchtime lipo, if you will. But, so when I tell you to think about mommy makeover, I know we've put a lot of shame on it. Because we don't want people to, a lot of people think that it's a cop-out. I'll tell you something. My patients work out. My patients do the diet. They don't eat jollof rice. They are not eating fufu. They are eating grass. Just salad. But that's one of the misnomers, is that you don't take, the people that come to me actually take care, they care so much about themselves that they're willing to spend the money to get back to being themselves. So it's not for everybody. But for the people that you're considering, should I do this? What I want you to ask yourself is, if I am to get whatever done, am I going to show up more as myself? Am I going to be a better mom? Am I going to be a better wife? Am I going to be a better friend?
Thank you so much for that. Honestly, thank you for removing the shame from that, because I know, like you said, there is a lot of shame surrounded around mommy makeovers. I know, like, I've seen it personally with the Nigerian community, especially. They say, oh, no, this is just how it's going to be. I said, Jesus Christ. And you guys you want to force me to have a child, and then my body will go boom, boom, bust, and that's it. I said, Lord, you're not making childbirth appealing. But like, no, thank you for removing the shame away from that. I will be taking that nugget, and I'll hit you up in maybe a few years.
We ain't got to tell them. Privacy, we ain't got to tell them.
Yes, ma'am. Thank you so much. So, Dr. Woodus, this question is, what vitamin deficiencies can affect women's hormones, and how can you balance your hormones? We are seeing an alarming rate of hormonal imbalance, people not even knowing if they're having hormonal imbalance, insulin resistance, all those type of things. So can you please elaborate a little bit on that?
There's a lot of confusion about hormonal imbalance, and I think it's because there's so many things that go into play when it comes to our hormones. So many things impact our hormones. It could be the things that we're describing, the things that I hear patients complain the most about are fatigue, lack of energy, low sex drive, irregular cycles, skin hair changes, low libido. Those are some of the more common things. And I think that as humans, we want to put our finger on the one thing that will fix the problem, and we want to go to our doctors and ask them to, give us that one magic pill or that one thing. But I think it's important to understand that it's like an onion. It's like layers of an onion. There's so many different factors that go into what someone really means when they say, I feel imbalanced, or I feel my hormones are out of whack. So it's important to have a comprehensive conversation about what the patient means, because what you mean by hormonal imbalance may be something entirely different from what the next person means. When you have those conversations, you start to understand that that person is not sleeping well. You start to understand that their diet may be playing a role. You start to understand that they're not moving their bodies. You understand that they are under immense stress in their job and their interpersonal relationships, that they have some undealt with things that, from their past that may be influencing how they feel as well. You start to understand that they have communication issues, body image, body dysmorphism concerns that are also throwing things out of balance. So it's important to start with a thorough history and a detailed conversation to find out, what does that even mean? Because there's so many different definitions when someone says that. It's also important to have a good physical exam. Is there something physical that could be influencing how you feel? We talked about PCOS and how that can disrupt our hormones, but are there other things that you're not checking for as well? Things that we're predisposed to, like diabetes, like high blood pressure, like cholesterol, that can also contribute to some of those feelings. It's important to do routine lab work. We talked about how PCOS is a diagnosis of exclusion, how it can look like other things, and so can hormonal imbalance when you really understand what someone means when they say that. So am I checking to see, am I anemic? Do I have vitamin deficiencies like vitamin D? Is my kidney function okay? Is my liver function okay? These are all things that are very, very important. Is my cholesterol high? And then once you start to kind of peel back some of that, you begin to understand that there is potentially a lot more than meets the eye when it comes to that conversation of hormonal imbalance. One of the telltale signs for what people most often mean is, what is my cycle doing? So understanding what is a normal menstrual cycle. Most people don't understand that your period can be normal if it's anywhere from 3 weeks to 5 weeks. And a lot of people also believe that just because it's not on the same day every month, that means that it's abnormal, when it's really not. So perhaps what you think is imbalanced is actually quite your norm. But it takes having that conversation. It takes really sitting, and it's not just going to be solved in a 15-minute clinic session. It's something that you have to be patient with. Understand that if it's something you've been dealing with for years and years, if it's something you've been waiting to talk to me about all year, I'm probably not going to be able to fix it for you in 15 minutes. It's going to take longer than just that one session, so we've got to both enter into that conversation with patience and with being thorough.
Thank you so much for that. This is the F word that we use amongst Black women called fibroids here. So this question is, how can women maintain a sense of hope and empowerment when facing a fibroid diagnosis, knowing that it can impact many areas of life? Heads up, women, you don't have to be pregnant to experience fibroids. That's correct, right? Okay. I just wanted to make sure.
You're looking at, okay. So let's talk about fibroids. Okay, we all have to talk about fibroids. So your uterus has 3 layers, okay? Where uterus womb has 3 layers. In the middle of there's the cavity, the uterine cavity, that's where a baby would be, okay? And then there is a lining around that. That's the endometrial lining. And then there's a lining on the outside of the womb. And then sandwiched in between those 2 linings is muscle. Your uterus is actually smooth muscle, right? And so that muscle has cells. And those cells are supposed to listen to your body, and they're supposed to grow, reproduce, and die. Well, one cell of the uterus that the uterine muscle can say, I'm not going to do what nature says. I'm not going to grow, reproduce, and die. I'm going to grow and reproduce and grow and reproduce. And then it's going to keep growing and reproducing. And it's going to create a capsule around it to shell it from other things. And then it's going to create its own new blood supply to feed it, okay? That now becomes a tumor, right? And that is a fibroid. It is a tumor like every other tumor that you've heard, but it's different from cancer in that it doesn't go anywhere, doesn't metastasize, doesn't go to your brain, doesn't go to your liver, it doesn't go anywhere else. But that doesn't mean it doesn't cause havoc. It just stays there and causes havoc there. So in that muscle, it can either be pushing into the cavity. If it's pushing into the cavity, well, you were getting ready to get pregnant. It's the right time of the month. There's sperm that's swimming up. And then it comes to this thing there. Or it was successful in swimming. And it went into the fallopian tube, and it met the happy egg. And maybe we joined with the egg, and they were going back together. And then they wanted to implant into the uterus to form a pregnancy, and there's a fibroid there. So it can cause infertility there. Or it can stay right in the muscle. You had your period. When your period is happening, in order for you to stop bleeding, right, in order for you to temper bleeding, your uterine walls actually kind of come together and tamponade or create pressure, just like you would create pressure if you were to put your hand on an open cut to stop it from bleeding. Your uterus does that on its own. But normally, the muscle is supposed to move, the fibers are supposed to move. Well, there's a fibroid there, so it's going to, and you just keep bleeding because it can't stop it. Or you experience pain because that is going to send signals to your body like, this is not normal, this is pain. So it can cause pain. Or it can stick out this way. So you look a little pregnant when you're trying to get pregnant. That's kind of crazy, right? That's diabolical. Like, it's literally looking like you're pregnant. Everyone's like, how do you do? And it's a fibroid. That might be bigger than the baby itself, right? Or it's sticking out to the front. Well, what's in front? Your bladder is there. So you run into the bathroom. You wondering, what's going on? You run into the bathroom. You're not able to sit through church service. You run to the bathroom, and you know that's a no-no. You run to the bathroom. Or you have differences in the way your poop looks. Sometimes you're constipated. Sometimes you're having diarrhea because that fibroid is sitting in the back, and You know, you move a little bit, it lets everything out. You had diarrhea. And then it's sitting in its in that little pouch that's there, and then you have constipation, giving you those things. I've actually had a patient who had fibroids so big that she had what we call two-body syndrome. What's two-body syndrome? She was really skinny up top, really big at the bottom. And y'all called it thick. But she didn't like that because she literally looked like two people. And why was that? She kept going to her doctor. Her primary care physician was telling her, you just gotta lose weight. So this woman was running, she was CrossFitting, she was Pilating till, 3-4 hours a day. And she was getting slim on top. But the big fibroid was impacting her lymphatics. So she wasn't able to have that fluid. So this is all fluid down here. When I actually did her surgery, I had to call a GYN oncologist to help me. That's somebody so I'm trained, I'm a GYN surgeon that only deals with people that don't have cancer. So I called in the GYN oncologist, not because I thought she had cancer. I called that person in because I don't know how to manage really, really sick patients. So I wanted that doctor to come in and do the surgery with me so that when she did go to the ICU, because all the fluid shifts, when I removed that uterus, all the fluid shifts, she was in the ICU, right? Because we had to manage her fluids now, because her body is not used to circulating like that, okay? So fibroids, even though they stay where they are, and we just say, oh, it's a little fibroid, it's a little growth, it's not that big, but that doesn't mean that every fibroid needs intervention, right? Because there are some fibroids that stay stable. They are literally like a pimple. Are they normal? No. But are they going to cause havoc other than being there? Not really. So there are some fibroids that it's okay to watch and wait. That's what that's called. But the problem is that when your doctor tells you, oh, it's a little bit, don't have to worry about it, you think, I don't need to worry about it. What did I say? Watch. I say it again. Watch and wait. So watching and waiting means you're having an ultrasound at least once a year. You got to watch it. Because if it was 1 centimeter yesterday or last year, and it's 4 centimeters this year, what's going on? It's growing. It's collecting blood supply. It's active. We need to do something about it. Okay? Now, if it's sitting in the cavity, and it's greater than 3.5 millimeters, and you've been trying to get pregnant, and it's not happening, that needs to be taken care of. Because it's clearly doing something that's causing you not to get pregnant. If it's causing you so much discomfort that you can't hold your pee, you look pregnant, those are reasons to get it taken care of. And there's a lot of things that we can do now that aren't all surgery. Okay? There is surgery. I'll be happy to do surgery. That surgery can involve us taking out your uterus. That can involve us doing, everyone should know this word. I'm going to use the proper medical terms because I believe that patients should know proper medical terms. You don't say, I'm just going to drive that thing outside. You're going to say, I'm going to drive my automobile, or I'm going to drive my car. So I'm going to give you the proper words. Myomectomy. Okay? Ectomy is the removal of muscle, remember we talked about that. It's a tumor that's formed in the muscle. So a myomectomy is the removal of that fibroid and a reconstruction of your uterus. We don't just fillet up the uterus, take out the fibroid, and do nothing about it. We reconstruct the uterus, presumably to allow you to have a baby. Because a lot of people are really afraid of that. I have had a myomectomy because God usually gives you your mission. He usually does. Like, your tears are not in vain. Every tear that you cry is shedded for somebody else. It's not just for you. So I've had a myomectomy. I had 8 fibroids, okay? I had both a hysteroscopic and a laparoscopic myomectomy by one of my dear friends at the same time. So you can do multiple things at the same time, okay? And I'm still going to have a baby, okay? I still got my uterus here. I'm still going to have a couple though, actually. So I want you to know that you can have a myomectomy. You can have your fibroids. I've taken out a woman she had 69 fibroids, and she has 2 babies. That God is not dead, and he uses doctors. That's why Luke was a physician. He put it in there for us to know. Luke was a physician. If he had a problem with doctors, he wouldn't have made Luke his disciple. I just don't understand. He has divine healing, and he's a potter that uses his pottery, okay? So those are things that we have to recognize. And then there is also the uterine artery embolization. What we do and what radiologists do is they're going to map out your fibroid. They're going to map out what blood supplies fill that fibroid. They're going to access those blood supplies either through your wrist or through your groin. And it's just like this big of an incision. And they're going to watch putting in the catheter in there, and they're going to put in what looks like microscopic dipping dots. And what that will do is it will block the blood supply to those fibroids. Remember, everything that's living needs to be fed with blood. That's why we need the blood of Jesus. But needs to be fed with blood. And so you can actually stop off that blood supply, and that fibroid will die. So that's an option. There are also options to use radiofrequency energy to either treat the fibroid that is inside of the uterus. The name of that procedure is called sonata, or it can treat you using a laparoscopic procedure. Literally, you're going to have tiny incisions like this, and we put in probes that basically open up like this, and the radiofrequency energy goes in through those probes, and that radiofrequency energy will make those cells not be able to reproduce or to be able to use the blood supply, so the fibroid itself dies. The muscle outside was not treated, so it's fine. It's fine. You're going to be all right.
Thank you so much, Dr. Ruthie. Thank you so much, Dr. Woodus and Dr. Janelle as well. We unfortunately have reached our time in our Q&As. Everybody say, oh, I know, right? But thank you so much for pouring out knowledge, pouring out insight. Can you guys give them a hand, please? God bless you. Thank you so much.